There you go. Thank you, Morgan. Hi, everyone. Wish you all a wonderful Happy New Year. Thank you for being here. And for those of you who are joining the first time, and I would like to extend a warm welcome. I am Malati Balasundaram, neonatologist and passionate FCC advocate. It's great to see so many familiar faces and names. Thank you for joining and for taking the time to prioritize your busy schedule. And all slides will be published on our website and fcctaskforce.org, and as well as shared in a follow-up email. So you don't have to worry about taking a screenshot or taking a note. So all will be shared after the webinar. Next slide, Morgan. So each of our webinars is dedicated to the NICU children of one of our speakers. Today, we have the honor of dedicating this webinar to Mike Swain and to his NICU children, Will, Sam, and Luke, and to Kate, who lived through it all. Next slide, Morgan. So we would like to share a few brief logistics before we begin. Please mute your microphone if you aren't speaking, and turn off your camera if you are multitasking. And we ask that all questions and comments, whether spoken or in the chat, remain respectful, non-discriminatory, and non-judgmental. So your cooperation helps us keep the space safe and welcoming for everyone. So as a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer, Next Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy that exists in healthcare and to empower everyone to contribute. Next slide. So I would like to acknowledge our webinar sponsor, Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, Mead Johnson, for sponsoring this webinar, and congratulations on over 120 years of leadership in pediatric nutrition. Next slide. This webinar is also sponsored by Small Talk, whose NICU egg system helps families stay connected with their babies during NICU stays. Thank you, Small Talk, for your efforts in ensuring babies are safely exposed to parent voices, which we know as clinical benefits for infant neurodevelopment. Thank you for your sponsorship for this webinar. Morgan will share our sponsor's website in the chat so you can learn more about their work. Next slide. A warm welcome to our new organizational partners, the Butterfly Project, Children's Hospital Neonatal Consortium, and Irish Neonatal Health Alliances, Not on My Watch, and National Institute for Children's Health Quality. Thank you for your partnership. Next slide. With that addition, we are now partnered with 63 organizations. This work wouldn't be possible without our organizational partnership. We appreciate relying on you all to share upcoming webinars, office hours sessions, and newsletters, and are grateful for the opportunity to spread the word about your events and achievements as well. It's incredible to see so many family-led organizations alongside healthcare professionals organization. And these organizations is part of what makes the FCC task force so special. Thank you. Next slide. We are so excited to announce that the Family Centered Care Task Force has received nonprofit 501c3 status. And thank you to Dr. Mitch Goldstein, whose nonprofit Loma Linda Publishing Company has served as a fiduciary home over for the past 3 years. And thank you, Mitch. Next slide. Since we are officially a nonprofit organization, there are some organizational structural changes, and we got our fancy titles, but we still all same roles and responsibilities. And all healthcare professionals are volunteer, including me. And we have 2 amazing family partners and a leadership team, Morgan and Kira. And thank you for your leadership. Next slide. To suit a growing need for quality improvement specific work, we have created a separate dedicated quality improvement committee, which will be co-led by Colby Day and Lillis. So thank you for your leadership, and I can't wait to see what this committee will bring into this year. Thank you. Next slide. So thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnosis, and that we represent birthing and non-birthing and bereaved parents, and thank you. Next slide. I also want to thank our multidisciplinary healthcare partners for their time commitment and support for this cause. As I mentioned, all healthcare professionals are volunteer in this work, and thank you for your commitment. Next slide. So I'm excited to share that we got over 3,000 members from 49 out of 50 US states, except Wyoming. And we heard there are no level 3 or level 4 NICUs in Wyoming. So if you know someone who cares for newborns in Wyoming, ask them to join us so we can complete 50 states. And 9 out of 10 Canadian provinces and 79 countries around the world. And since our November webinar, we are welcomed almost 200 members. And thank you to Morgan for keeping us all organized. Next slide. So on to the committee updates, and Carrie and Nicole continue to work on our present study toolkit creation, which will support NICUs in implementing unlimited parental presence, even in the face of respiratory pathogens like COVID-19. We are grateful to Angel Eye Health for their support of this work. Next slide. And last year, Jesse and Mia created a position paper to show our community where the Family-Centered Care Task Force stands on the importance of equity, diversity, inclusion, belonging, and justice in the NICU. In 2026, this year, they plan to create a toolkit around ensuring silent signals in the NICU are consistent with the FCC values, and bring an EDIBJ lenses to our work to ensure it is reflective of our commitment to health equity. Thank you to KSC Independent Educational Grant for their support for this toolkit creation. Next slide. And Daphna and Alex are busy sharing FCC task force related events and resources and advocacy opportunities and education on our social media platforms. Please take a moment to follow us. We invite you to tag us in your FCC related content so we can easily share and promote your important FCC work. Thank you. Next slide. So it's great to have Morgan and Bob to lead this newsletter committee and several contributors to make this newsletter the best educational resource. The newsletter committee plans to release its winter publication by the end of this month. If you are struggling to get buy-in for your FCC work, and share this quarterly newsletter to your clinical and leadership team. And so we heard from our small group QI work, and if you share this resources, then you can get better chance of getting a buy-in. And next slide. So we invite you to share your unit experience with holding during cooling, the therapeutic hypothermia for infants with HAE, hypoxic ischemic encephalopathy, to support others as they seek to implement this practice. So take a minute, it's a 2-question survey. Go ahead and scan, or Morgan will put this a link in the chat so you can complete, and whether you are practicing or you are not practicing. If you are practicing, please share your protocol or guideline. And if you are not practicing, share what are the challenges you are facing. And additionally, this April 2026, in honor of HAE Awareness Month, the Newborn Brain Society and Hope for HAE invite you to join the Polar Bear Care Hold-a-thon. And this initiative centers on trauma-informed family-supported care and aims to increase awareness of the safety and feasibility and benefits of a patient holding during therapeutic hypothermia. Next slide. So we are excited to share that our monthly office hour sessions are changing to accommodate a growing audience and desire for FCC implementation strategies. So we will be alternating some open forum and session, and also some short presentations from folks who have successfully implemented family-centered care practices. So with the time for question and answer session. So we are changing the name from office hours to FCC Community Exchange to better fit the new format. Next slide. So we have presented 23 webinars so far. This is being our 24th, and it's all on our website, and there's a database, so you can go and then subscribe to our YouTube channel and listen to our previous recordings. So that's for you, and you can share it with your colleagues to improve your FCC practices. Next slide. So we appreciate your feedback, and we understand it can be challenging to access our website, current website's resources through Google Drive due to hospital firewalls. So we listened and decided to upgrade to a new platform to better serve you and your needs. And thank you to Smalltalk for supporting this work. And so stay tuned for more dynamic and user-friendly website coming soon. Next slide. So if you are a NICU parent and our children experienced bronchopulmonary dysplasia or chronic lung disease, and please take a moment to go complete this survey study that Global Foundation for the Care of Newborn Infants is seeking families of children born preterm to participate in this study. And Morgan will share the link in the chat. And share this with your families in your NICU. So if you're a healthcare professional, share it with your FPC, so we can hear more from US-based family, so how they are experiencing this diagnosis and how we can improve. Next slide. So we invite you to register for the 39th Annual Gravens Conference. So the date and location of this amazing event is changing, but you can expect the same great topics and workshops and abstracts. An abstract site is open, and share and your FCC related work, and you can register, and you can book the hotel. So hope to see you there in June. So with that, I will pass it to Kira to introduce our first speakers.
Thank you, Malati, and hello and Happy New Year to everybody. Thank you so much for joining today's webinar. I am so thrilled to introduce two very dear friends and colleagues who will be starting us off, Christy Gliniak and Sue Ludwig. Dr. Christy Gliniak is a neonatal therapist who is deeply committed to advancing neuroprotective, family-integrated developmental care practices in the NICU. Her research, innovation, and advocacy efforts target neurodevelopmental, early relational health, trauma-informed care implementation, and neonatal sleep. Christy is also the communications manager and conference co-chair for the National Association of Neonatal Therapists. She is an associate professor at Fielding Graduate University and a visiting researcher at UMC Utrecht in the Netherlands and Stanford University. Christy is an executive council healthcare partner with our very own Family Center Care Task Force and a board member of the National Perinatal Association. Her favorite roles include international consultant, spouse, and mother of two. Sue Ludwig is passionate about improving the quality of life for babies in the NICU and the professionals who serve them. She is a sought-after speaker, consultant, and truly gifted writer. A licensed occupational therapist and board-certified neonatal therapist, she is president and founder of the National Association of Neonatal Therapists. Sue has received multiple accolades from organizations and companies inside and outside the healthcare arena. Her award-winning book, which is a must-read for anyone who cares anything about the NICU, called Tiny Humans, Big Lessons, How the NICU Taught Me to Live with Energy, Intention, and Purpose, translates lessons from the NICU into powerful insights for life and leadership. Sue lives in Cincinnati, Ohio, with her husband and a couple of dogs, and has two grown children. Welcome, Christy and Sue.
Thank you so much, Kira. I can share my screen. Okay. I will get that started first. Okay. Are we good there? Okay. Well, first, Christy, on behalf of Christy and I, we just want to thank everyone, thank the FCC Task Force for the invitation to present today. It is really fun and congratulations, by the way, on everything that you have done and created. It is quite inspiring and amazing. And taking notes. So thank you for everything. And it's really fun to see so many names who are present here today that we do know, and so many names that we don't know. So I'm just really excited to meet you all and talk with you today. Let me get here. So we have a couple of objectives for this session today, but I want to just really say that the reason that we're using neonatal therapists and NANT as an example throughout this presentation today about what it looks like to break down professional silos is not because NANT is doing everything perfectly or anything perfectly, or that we have everything figured out. But what we do know is that we know our specialty well, and we know this group well, and we've learned some things over 16 years of NANT and trying to bring together 3 different professions for one purpose. And so we hope to share some about that with you today. And also that, OTs, PTs, and SLPs have not always gotten along. And that might be shocking to some people and not to others, but what we know is that if we can figure that out, as we have in NANT, that it's possible for all of us in every specialty and including all of the families to do this collaboration thing well. I want to start with just a little pre-NANT story, kind of before the beginning. Oops. And this was back in 2008. When I was literally laying in bed one night, and I had to work at the hospital in the morning as a neonatal OT, and I couldn't sleep because I was vacillating back and forth about whether or not I should be the person who starts this national organization for therapists. And no one knew I was thinking about this. It would have been nothing if I didn't do it, but I kept looking for another leader. I kept looking for someone other than me to start this thing, this idea I had to serve therapists. And I couldn't make the decision, to be quite honest. It was a lot of risk. I didn't think I was the right person. And what finally came to me some hours before I had to actually be at the hospital was that I was seeing this mom and her baby, who's the little guy in this picture, at 9 a.m. the next day. And what I knew to be true about her was his mom was that she trusted me, that we had been working together for quite a while in the NICU, and that she had this really amazing trust in everything that we had worked on together. And what I knew at the time from consulting to other NICUs in the country was that I couldn't swear that every other therapist I knew in the country had been trained well, had oriented well, did they really know what they were doing? And at that time in 2008, I knew the answer was no. And what I knew about this mom that I was showing up to see in the morning is that she deserved, and she assumed, I'm quite sure, that every single person that was coming to see her baby in the NICU was specially trained to see patients and see babies like hers. And that would be a huge assumption on her part at the time. And so it is really I couldn't from that moment on imagine not doing something to try to make that true. And I knew that every therapist I'd ever met just wanted to do the right thing, and they wanted to do it well. And so everything that I also, in the middle of the night, was thinking I could do this just for occupational therapists, which was my profession. But what I knew then, and is absolutely true, is that when we focus on what babies and families need instead of what we're trying to do as a profession, really, that it was clear that the babies and families would benefit the most from all 3 professions being in the NICU. And so that this had to be a somewhat unusual but collaborative adventure together with all 3 professions. For anyone on this webinar who just doesn't know who the heck we are and what we really do as neonatal therapists, this is the official long definition, which I will not read to you, but a couple of things I would just want to point out are that neonatal therapy is a specialty that is comprised of occupational therapists, physical therapists, and speech language pathologists who then specialize in the NICU. And so we do have 3 different separate educational backgrounds, but we have come together in this organization to, because we all work for and care for babies in the NICU. And what we are trained to do, what we're educated to do, and what we love is neurodevelopment. And so when we are working with babies in the NICU, we are thinking not only how do we support their brain and sensory development in this very moment right now that we're in, but how does that moment then lay the foundation for better neurodevelopment for the lifespan? So we're always thinking of the moment that we're in, and we're also thinking of what that child is going to be dealing with in kindergarten. So we want to help prepare that baby's system for everything they might encounter in life, and we want to do that in relationship with their family, as it should be. And we wanted to do it in this multidisciplinary way. But in order to do that, we had a long way to go in the beginning because we were in our little silos. I'm just getting this Zoom thing out of my way for 1 second. Okay. So we wanted to talk about silos today and the breaking of professional silos in service of our patients and families, because we think there is still a lot of it that goes on in the NICU. And what that means is that we're all sort of working independently in our different professions and not sharing enough information and collaboration and not including the family enough. But I wanted to back up a little bit and just say that we did begin in silos for good reason. We are all officially separate, whether it's 3 different therapy professions or all the professions represented here and in the NICU. We each have a separate educational background and requirements. We have unique perspectives and preparation. We have unique skill sets. We have different roles that we fulfill. We have different competencies quite often in various professions. And we have to have all of those things so that we can represent what we have been trained in this environment. So there is a value to having these silos that we were kind of raised in initially. One thing I want to point out, alongside of all the silos we might have in the NICU, is that families have a silo. And while we're considering how all of us are trained and what we bring with us in our own experiences, I want us to also consider that families bring all of their own experiences and their background and their knowledge. And that is something that, whether we're talking about what's in a silo or we're talking about what it looks like when we break them down, that we have to include the family as well. So the value of breaking down silos is not going to be surprising. The value of breaking them down is that all the information and the knowledge and the skills and the passion and all the things that are in those individual silos get to be shared out in the open. So instead of us kind of bumping heads or saying, is that really your role or my role? Or looking at, I know between OT, PT, and speech, a lot of times there is a pretty adversarial relationship in many, not just the NICU, but in many places about who does what. And so when we get really clear, we talk to each other. We look at where the clear overlaps really are. Like for NANT, we have a core scope of practice for where these disciplines overlap, but that does not mean that we are trying to melt everyone into the same profession. We are valuing our uniqueness while we're also sharing common ground. And when we do that, the babies and the families benefit. And we also benefit as professionals, because suddenly, instead of just knowing what's in our own silo, we get to pull on the experience and expertise of our colleagues, which is invaluable. One of the clearest memories or examples of this, I remember being at a NAT conference, and Karen Bradley, who's a PhD PT, was on stage speaking. And much contrary to what sort of the stereotype would be, she was a physical therapist speaking about feeding. But what her research was in is if I don't get this wrong, hopefully, but is in respiratory waveform variability during oral feeding. So she was bringing her very unique physical therapist perspective of the respiratory system and cardiac and everything that goes into breathing, but then looking at it and how it is affecting feeding, which was a quite different approach than anything we had heard before. And I remember thinking, wow, like this is a whole new thing that in this room of all of us, we now get to bring these things together instead of being at a PT conference, an OT conference, a speech conference. And those things all have their merit. But now we all get to learn something very new because we're sharing knowledge outside of our silos. And that can only mean good things for babies. So I'm going to pass this over to Christy, and she's going to take us on a deeper dive into the benefits of collaboration.
Thanks, Sue. So how does breaking down these professional silos impact family-centered care? We all know family-centered care isn't about our individual contributions, but it's really about how we work together as a team and the collective impact of those efforts. And Sue did a great job of telling us how breaking down the silos will improve the sharing of knowledge and also help us optimize the individual skill sets. But when we also step out of those silos, we really begin to see the baby and the family more holistically, rather than viewing them through the lens of our single discipline. And so when that knowledge is shared, care is better coordinated, and the environment itself becomes that much more supportive. So that sets the stage for, I want to challenge everybody to think about the NICU as an ecosystem, where every single role, every relationship, and every interaction contributes to infant development. So let's explore that ecosystem on the next slide in the NICU for just a minute and think about how that's going to really influence development. An ecosystem, just by definition, is a community of organisms that interact with each other and with their environment. So in the NICU, that includes infants, parents, NICU professionals, and the environment, and they all influence one another. And of course, the baby's development then is shaped by these relationships. So family-centered care, of course, thrives in this ecosystem because the baby is never seen in isolation. Instead, we consider the full context of their care, the relationships, the environment, and the team interactions. And how we collaborate as a team, of course, includes the energy we bring to the bedside, our communication styles and words, and the sharing of knowledge. And then that all together fundamentally shapes that healing environment. And this perspective, I think, helps us understand how these siloed organizations or these silos have hidden costs. And those hidden costs can be big for infants, families, and for staff. So jumping to the next slide, I want to dive into that for a minute about the invisible divisions within the NICU that can affect our accountability, our communication, and really the quality of the care we provide. And then that, when our teams are operating in isolation or what can feel like a vacuum, then the challenges begin to show up in very practical ways. And some of these will resonate with you. Our guidelines between disciplines can be inconsistent. We can deliver fragmented care. We can also kind of look at each other, who's going to take that on when their accountability becomes unclear. Decisions or even our care can be delayed. And then the worst, I think, in this environment, many people can recognize that sometimes this results in mixed messages. Families get mixed messages, which is really frustrating. And that tension can start to build and conflicts can start to come up. And then we lose trust with each other. And that's really detrimental. So parents lose trust in the NICU team, or between colleagues, we lose trust in each other. And that's why this strong interdisciplinary collaboration is really so essential. To understand how these dynamics really connect to infant development, I want to nerd out with you for a minute and talk about Bronfenbrenner's bioecological model. So some of you may know this model and some of you may not, but as you can see here on this slide, Yuri Bronfenbrenner's bioecological model reminds us that infant development really doesn't happen in isolation. It unfolds within these multiple interconnected systems that ultimately shape the development of the infant and the family. And at the center of this model, you can see is the microsystem, and that is the infant's immediate environment. And this includes, of course, parents, NICU caregivers, and the NICU environment itself where the baby space is. And it, of course, has the most direct impact. It includes parents' cultural values, their beliefs, their language, and of course, the hands-on care, the hands-on NICU care they receive in the isolette. And then if you look on this diagram into the blue section there, that's the mesosystem, and that's kind of the section where it shows how the immediate environment and the outside next row interacts with one another. So, for example, how parents communicate with the NICU team, perhaps including grandparents or siblings, how that extended family is incorporated. It's going to be related to the hospital care links, maybe specialists coming in, or community support, such as the outpatient clinics and teams that receive our families, or even the Ronald McDonald House, where many families are staying at the time. And so moving outward again into the green here, into the exosystem, the macro system, and the chrono system, these kind of shape families more indirectly. The exosystem in the green really includes parents' workplaces. And why does that matter? Well, time off, it matters about the income they have, it matters about what insurance, policies they have. So these things actually do shape our care. And again, the macro system, so moving into the gray, this is the laws. These are the government policies that are in place, the cultural influences of the region they're being cared for. Maybe it's not the region that they live. Sometimes these are factors like faith-based practices and what have you. And then this lighter ring on the very outside here, this is the chrono system, and this reflects life events and historical contexts. So for many of you in this space here, that can be things like prior preterm birth. It might be perinatal loss that really influences care. It can be societal events. We all had to live through COVID-19, so things like that. So getting out of those boundaries, as you can see, we can consider other things. And looking at the layers together helps us move beyond these silos and consider the full social, cultural, and historic context. It allows us to provide care that's more culturally responsive, it's more individualized, and it's really truly family-centered. So on the next slide, I want to think about how we can do that and how we can do that well. And to reduce those silos, these are some strategies, but really it's about creating a better and a more powerful healing environment, one that's very nurturing and supportive. It begins with creating conditions that enable teams to work seamlessly and work collaboratively. Digging into the literature, I came across the highly reliable teams literature highlighting 7 core factors, or the 7 C's. And these are illustrated for you on the slide, and I'm not going to read them exactly, but there's cooperation, coordination, communication, of course, so those make sense. Cognition, I had to dig at that one. That is the understanding of our roles and abilities. And then conflict resolution. We really want to have psychological safety when we're working with one another, and to provide that for families, and conditions of support. When these elements come together, our silos begin to dissolve, and our teams are more cohesive, responsive, and more effective. It's not just good for teams, right? It's better to work in those environments, but it's also transform this healing environment, which is better for families. And because of that, when our smooth teamwork is in place, I'm going to hand it back to Sue, and she can talk about how that really can impact development in its long-term place, or its long-term part of this journey, and also how we can really foster belonging.
Thanks, Christy. As Christy was describing, just the evolution of silos to collaboration improves our outcomes by transforming the environment of care. And we talk a lot about environment, but we are all part of that environment in very nuanced ways. It includes every professional, every family. And together we become part of this. When we break down the silos, I think, and we're responsive to each other, the environment of care becomes more responsive. It allows for the complexity that these babies need and demand in this place that they are in and the families within them. We are dealing with a very complex, nuanced environment, and it's full of stress. And in order for us to continue to support each other and support babies and families, the more that we can break down the silos and work on communicating and collaborating, really the healthier the entire environment becomes for the infant. So not just the physical environment, but a lot of those things that are very difficult to name. I'm sure the parents, NICU parents on this call could name a lot of them, experiences in which the environment was not supportive and a lot of experiences in which it was, and that sometimes there's something pretty intangible. And so I think the more that we're working together, the more we can create value and create belonging and support, seeing each other all as just contributing to this one cause. And when we work together like this, we really do affect the trajectory of a life. And I think that's something that is why we are all here literally today on this call, on this webinar, is because that's the purpose we all signed up for. We have a little video for you, but I just want to preface it by saying it is a NANT conference video, but that is not why we're showing it. It's not a yay NANT thing. What I want you to, the reason we chose to show this is because in knowing now a little tiny background about sort of where therapists have come and maybe not always collaborated and how we have tried to move forward with that, we just wanted you to be able to, not just in these words that we're sharing, but we wanted you to be able to see and hear and feel what collaboration over 16 years can look and feel like. And we can say it all we want, but we wanted you to experience it with us. So that's what we're going to try to do, if this plays for us. Together, we've been on a mission for 15 years. We started so small, just like some of our favorite humans. We began by planting a seed in the ground. We belong. We are valuable. We contribute to better outcomes. Then you did an amazing thing, and you grew. 50 states, 1,400 hospitals in 30 countries, a passionate global community. You conducted vital research, advanced clinical practices, pursued certification, embraced national competencies, presented to big audiences on huge stages, and used your voices for those who have none. You learned to lead in new ways. You showed up for each other, your teams, yourselves. And most importantly, you improve the lives of hundreds of thousands of babies and families. They will thank you with the rest of their lives. We will support you for yours.
I believe that this represents a step for NANT that signals both our members and clinicians in other fields. We have arrived.
Cheers to 15 years of impact. Please tell me that all the music was playing. Okay. So I hope that's just a little energetic example of when we come together and we are willing to not look at what we're protecting in our own professions, but look at what we're able to share toward a common goal that it changes the world. So, gosh, that made me emotional for reasons I was not expecting. And so that is all we have presentation-wise, but we would love to hear any questions from you guys.
Thank you so much, both of you. I'm wondering because, we know that bringing folks together that have maybe a common interest, but also very different views in how to go about that common interest can be challenging. What challenges did you find when you were first bringing your your silos together, and how did you overcome them, or how did you kind of really uh, get the message across about why collaboration was going to be so important for your disciplines in neonatal therapy?
Hmm. Great question. Do you want me to start with that, Christy?
Sure, I can follow if need be. Sure.
Okay. So in the beginning, I think, like a lot of things, we had to decide who we were and we had to decide who we weren't. And so we had a pretty right away, we formed a professional collaborative that had equal representation of all three disciplines, so that we were going to filter those early decisions through that multidisciplinary group. So right away, we were saying everyone matters here, and we're going to have the same representation. And then, but we had to make some decisions. Were we also respiratory therapists? Were we also other kinds of therapists? So we had to make a lot of decisions early on, and we did it through that multidisciplinary group. And I think that as far as a part of the question about how to kind of make that collaboration focus known, is that we were, I think, clear from the beginning that yes, we were going to a professional organization, but we were just so rooted in the why of what we all wanted to do and the why of the specialty, which was supporting babies and families in the NICU. And that's something that no matter what we disagreed on, which there's lots of healthy disagreement, which is great, but no matter what, we could come back to the passion of who we were supporting. So sometimes we do that by, we still do this sometimes to remind ourselves, is we'll take, a little teeny tiny NICU diaper. We'll take a little teeny tiny something that represents something meaningful to us and put it in the middle of the table for a meeting. And that way, no matter where the meeting ends up, we know where we're coming back to in the center. So that's something we try to always keep front and center. And hopefully that answered the question of the beginning too.
Absolutely. Christy, did you want to add anything?
Sure. I mean, just on a smaller scale, like in a NICU, there's, we don't own one part of of the care than the other. So, looking at maybe adult stroke rehab, there's a little bit more specializations. Occupational therapists tend to be really known to deal with upper extremities more than the ambulation versus, different roles. But, babies, they don't have as many occupations at this stage of the game. So we really overlap more. And I think what's really cool is, and when I share this at the bedside, when we are all filtering the observations through our own lenses, we just bring better tips and trades. And I think that what's really important, I think, for therapists and the broader team is that when we come in, like we own something or we're the expert, that's really unfortunate because we're a team player. And, of course, the parent is the expert in the long run with the nuances of that particular infant. But I think when we come in and say, how can I contribute what I know and how can we communicate better with each other, then bringing in all of those little tidbits, we're really going to dive into deeper. Like, for example, with feeding, we're going to know more about the respiratory or the position or the environment, and then how we can communicate so we're all doing it that way without owning a specific thing. I mean, we wouldn't begin to give IVs or do different things because it's not in our scope of practice, but we do overlap with nursing and with other team members quite a bit. So making room for each other. And just one last piece is that in the US, I'm really excited. I'm a Canadian trained therapist, and we all are in this different piece of evolution. And I think that in other countries, for those of you that are on the call from different countries, some of you may just still be using more of a rehabilitative type of model when it comes to therapists in the NICU. They wait for something to be identified as not going well. And I think that we're really trying here to be more involved sooner with the preventative approach. And so we're here as a support for clinicians in other countries that are still trying to pioneer this in their spaces.
Thank you. Well, unfortunately, that's all the time we have for questions. But I know I did see a few questions that were in the chat. So Morgan, maybe what we could do is capture those questions and email Sue and Christy for responses that we can then include in the wonderful recaps, if that's okay with everybody, because we want to definitely save time for the next presentation. But thank you so much, Sue and Christy. This was really, really wonderful. Thank you for sharing.
Thank you, guys.
Thanks so much.
I echo Kira. Great presentation. I absolutely love the systems diagrams. I think those are really special, and I think that should be a basic piece of education for all healthcare staff. I'm excited to introduce our next speakers. If y'all would like to share your screens, Cameron and Mike, please feel free to do so now. Dr. Cameron Boyd is an attending neonatologist at Cook Children's Medical Center and affiliated hospitals within the Pediatrics Fort Worth Group. He has co-developed and facilitated NICU dads groups and has been involved in research focused on supporting fathers, non-birthing parents, and families in the NICU throughout his fellowship. Mike Swain is a NICU parent to twin boys born at 29 weeks gestation and a son born at 30 weeks gestation. His family was cared for at Ann and Robert H. Lurie Children's Hospital, where Mike is the co-founder and parent leader of the NICU Dads group there. Thank you both so much for joining us today, and to you, Mike, for sharing your family's story for the benefit of all of us. I will go ahead and pass it off to you.
Thank you so much, Morgan. And hello, everyone. Happy New Year. Thank you for joining us on today. Mr. Mike, are you ready to go?
I'm ready to go.
All right, let's do it. Before I begin today, I would be remiss if I did not pause for a moment of silence for all who are hurting and mourning on today, both domestic and abroad. As a child, I was taught by my parents and loved ones that I am my brother's keeper. And when one of us hurts, we all hurt, no matter if that's in the NICU, in the hospital walls, in our country, in Minneapolis, or anywhere else in the world. There are people hurting on today. Listening, responding, and acting when others are hurting is the essence of family-centered care, and it is the essence of people-centered care. So let us take a few seconds to pause. Thank you. So getting started, the presentation is titled The Power of How Are You? Because sometimes the simplest question can have the biggest impact. I have no financial disclosures or conflicts of interest. And in this presentation, the terms father and dad are used interchangeably. While this talk focuses on fathers in the NICU, we recognize that all parents and caregivers deserve support and are essential partners in family-centered care. So objectives for today are threefold. The first, to understand the needs and perspectives of fathers in the NICU, to learn strategies to engage fathers and non-birthing parents at the bedside, and last, explore the importance and structure of a NICU dads group. So, how are you? And this question may be more pertinent now than ever. This picture came from the LA Times during the pandemic at the height of mental health concerns and people who were dying. And this question still holds true today. How are you? As a child growing up in rural Martin, Tennessee, this question was commonplace for us to ask family, friends, anyone that we came into contact with. And as a child, I would wonder why we would ask this so much and so often, and in fact, if it was genuine or not. And it became more of a routine to the point, so when I moved to Chicago, Illinois for fellowship and asked people both at the hospital and the community and anywhere else. How are you doing? People will look at me strange. And even though this question may be somewhat routine and mundane, I still feel like it's very valuable and something that we should be curious about, both in the NICU, when it comes to the baby, and also when it comes to the parents and caregivers. So this is Mr. Mike Swain years ago. And how were you doing then, Mr. Mike? How were you when you were in the NICU?
Thanks, Cam. So all of you, I'm very humbled to be part of this. Thank you. I did blur my screen. You can probably tell I'm in my car. I am parked. I'm not driving. Don't worry. Um, yeah, but Cam, thanks. I know my wife provided you a couple of pictures, and this, you look back and it all comes back to you. This was 11 years ago. Um, just briefly, a quick bio of who I am. My name is Mike Swain, father of four: Sam, Will, Kate, and Luke. Sam and Will are fraternal twins. They were born at 29 weeks via C-section at Prentice Women's Hospital in Chicago, at 3.5 pounds and 3 pounds, respectively. They had an 8-week stay in the NICU. Very, the typical scary things for first-time parents, but nothing major, and we made it home. They'll be 20 years old in April. Will is 6'5", Sam is 6'3". I would never admit this to either one of them. They're both stronger than me. They attend college together and live together as roommates. Kate was our easy birth. She made it term at Prentice Women's Hospital. She's now 17. Though we had no major medical expenses with her. As my only daughter, she tries to be the most expensive child with her constant text messages for Venmo or transfers for her $9 coffee drinks. Our youngest, Luke, wins the prize of most expensive child. Our NICU journey began long before Luke was born. During the first trimester, we learned he had severe, and apologize, I can't pronounce the medical terminology. There was no fluid. It was caused by placental failure. We were told he had a 0% chance of survival. He would likely die in utero or be stillborn. And if he did survive beyond birth, he would have no quality of life, and termination was recommended. We are a family of faith and felt we weren't able to make that decision on our own. So we rode through the rest of the pregnancy. Luke was born at 30 weeks into a room full of maternal fetal medicine and NICU providers at Prentice Hospital, which is attached to Lurie Hospital. He required immediate high-frequency ventilation due to profound pulmonary immaturity. And over 5 months in the NICU, his course included grade 3, grade 4 IVH bronchopulmonary dysplasia, pulmonary hypertension, hypertrophic cardiomyopathy, feeding intolerance, and Noonan syndrome. As parents, we live the daily tension between hope and fear, learning medical language we never expected to know, advocating through rounds, celebrating small wins, embracing for setbacks, all while raising 3 other children at home. Luke had 2 open heart surgeries in 2 weeks at age 3, and now lives and received a pacemaker, and now lives 100% paced. Today, Luke is a thriving 5th grader. He's an athlete. He loves building. He loves to DJ. He goes by the name DJ Dark Knight, and he's a kid who loves life fiercely. Important to know, what carried us through the NICU wasn't the advanced medicine. It was feeling seen, heard, and included as parents in every decision about our child. And that's something that drove me to be part of this effort with Cam and the Dad's NICU group. Thanks, Cam. Go ahead.
Thank you, Mr. Mike. So looking back to this picture, do you remember specifically or generally how you were feeling at this point in time in you all's NICU stay?
You know, having been through the NICU with my twins, I thought I was prepared for it. This was something new. You know, you're dealing with a much sicker child. I think there I probably was trying to get him to hold my finger. He was on the high flow vent at that time, and you know, every day we thought he was likely going to pass away in the early part of the stay. You know, it's the fear everybody has is just the unknown. You fear what you don't know, and you know, we were dealing with medical complexities that even though my wife is medically trained, she's a physical therapist at Lurie Hospital and knows a lot of this. You're just dealing with something new, so it's the fear of unknown.
Thank you. So understanding father's unique challenges in the NICU. Mental health in the NICU, about 40 to 50% of NICU parents experience clinically significant levels of depression, anxiety, and trauma. And when it comes to literature, looking at fathers or parents in the NICU, overall, through a recent PubMed search and study, you can see that overall parent publications for mothers are a lot more than the overall parent publications for fathers. And when you look at NICU publications, only a fraction of those overall publications are NICU publications, either for mothers and fathers. And this number is approaching less than 1% for NICU fathers publications in literature. So what about the dads? Dads report in studies of feeling sidelined in caregiving roles, guilt, helplessness, loss of control, as Mr. Mike had mentioned, fear, balancing roles, partner, provider, parent, caring for their own well-being. And looking at another study, you can see the breakdown, and this is just self-reported numbers of parents who deal with mental health issues such as anxiety, depression, and stress. And the point that I want to drive home here is the number is not zero for either parent. Specifically, when speaking about fathers, the number is not zero for them either. And this is a publication, a study that looked at depression screen scores, both in the hospital, at discharge, and after discharge for moms and dads. And you can see that highlighted in the yellow circles, the scores for dads and the odds risk for dads barely moves after discharge 30 days later, signifying that there is help that is needed for dads in the NICU that may or may not be addressed. Another study, which was done by my mentor in fellowship, Dr. Craig Garfield, showed cortisol levels that continue to increase for dads even after discharge, while moms plateaued and start to decrease at 14 days later after discharge as well. Again, signifying that dads are in need of help and support. I thought that this was a very interesting picture that showed that problems exist in the NICU, oftentimes exist prior to families even making it or arriving to the NICU. You can see multiple factors on the left-hand side that are highlighted in yellow, and how these family and social circumstances and mental health issues may play a role in the parent's state of mind once in the NICU and even after discharge. And you can see in the middle of the picture that the role that we as clinicians, the role as we as partners for parents play in the NICU environment and helping parents to cope. Long-term impact for families look like a multitude of different things. NICU stress affects relationships and bonding. Long-term mental health implications. There are long-term behavioral implications for the family unit and child. And family-centered care can reduce negative outcomes. But one of the things that we wanted to talk to you about today, and one of the things that Mr. Mike wanted to highlight, was the role that finances play in long-term impact on families. Mr. Mike, did you want to speak to this?
Sure. Yeah. Again, going back to one thing I said earlier, the fear of unknown. I mean, you have your obvious financial stressors when you have a long duration in the NICU, and it could be as simple as, parking fees, lunches, meals, daycare if you have other children. Trying to think what else, but I think the biggest one's the unknown of if any of the parents on here, you were served with, your first 30-page invoice from the hospital and not knowing what insurance is going to cover, arguing with the insurance providers about maybe something that got mislabeled and you have to go back and have a doctor or a care provider relabel something to get it covered. I mean, these are $1 million+ babies, and not knowing how much of that you're going to be on the hook for, so to speak, depending on your insurance provider, is scary. That's the unknown. So that was, having gone through it with the twins the first time, which nearly broke us. We didn't have great insurance. We did, when Luke was born, have great insurance. However, you don't know. So that's always in the back of mind.
And here's a study that was published in the Journal of Pediatrics that showed healthcare costs for major morbidities associated with prematurity in U.S. children's hospitals. There were almost 20,000 children that were looked at in 30 different institutions. And basically, the earlier the baby was born, the more comorbidities that the baby had, and the more severe the morbidities were, increased the costs, which Mr. Mike just alluded to, costing nearly $500 to $1 million upwards. And as Mr. Mike just mentioned, those are long-term financial impacts. The short-term financial impacts look like lost income, missed work, travel, lodging, childcare, the list goes on and on. So how are we partnering with dads in the NICU? First, we must take a look at some of the potential barriers to engagement with fathers. These include work commitments and societal expectations, the whole idea of masculinity, self-expectations, the Superman mentality, limited resources tailored for fathers, which is something that we're going to be hopefully addressing with you all today. And one of the most interesting and pertinent barriers in the NICU is us, the medical team. So what fathers say they need: clear and direct information, emotional support and inclusion, opportunities for hands-on care and support, and practical support. Here is just a picture showing when the medical team can engage or look to engage fathers and non-birthing parents in the NICU. And as you can see, the point is at any point in time their NICU stay, whether that be right after the baby's born. A lot of times this is when mom is still recovering or the birthing parent is still recovering. Anytime during the NICU admission, mom's first visit, anytime during the hospital course, and even thereafter. Another important way to engage dads is by encouraging skin-to-skin care. We know through studies, some studies, that skin-to-skin care decreases paternal stress, it strengthens father-infant bonding, and encourages early caregiving involvement. As far as personal strategies, we can make simple eye contact with dads, acknowledging them, that they're in the room and that their opinion, their input matters and is encouraged. We can reflect on and minimize biases related to gender, race, ethnicity, and socioeconomic status. We can encourage early participation in care routines, facilitate open communication, and offer flexible care policies for all parents and families in the NICU. As far as bidirectional education support, there are resources that we can provide parents, both parents, specifically for fathers, pamphlets, videos, and workshops. And then most importantly, creating a welcoming environment by educating staff to recognize and address paternal needs, having pictures and images of fathers in the unit, which is something that can be so simple, but oftentimes forgotten about. Having or expressing inclusive language, flexible visitation policies for parents who are, and non-birthing parents who are back at work or may have differing hours, and the overall NICU design. So getting into the meat of this presentation, we want to talk about the NICU Dads Group, which originated several years ago, again, with my mentor, Dr. Craig Garfield at Northwestern Prentice Women's Hospital. He had the idea of finding ways to engage dads. This was during the pandemic, so at first it started off as virtual. And then as a fellow, we kind of revamped the program, him and I, and made it in person and had a lot of success in doing so, that we'll talk about later. So the purpose of the NICU Dads Group is to provide a dedicated space for fathers navigating the complexities of having an infant in the NICU. The structure looks like monthly meetings in person in the NICU, if possible. 1 hour casual atmosphere refreshments, which is something the dads are always excited about and something that's been funded, fortunately, through both hospitals, the level 4 and the level 3 that we have the NICU Dads Group at. Hosted in a central location in the NICU. And probably a thing that is definitely important to us, Mr. Mike as well, is making this a safe space for fathers and by having a fathers only supportive environment. Here's just a glance at the agenda, a typical agenda of the Dads Group. You can see we start off with welcome and introductions. If there is a guest speaker, such as a veteran NICU dad, they are asked if they feel comfortable to speak and share their story. And then there's educational discussion that is had. We also mention and talk about the NICU virtual library that we created and give out instructions to, or give out the link to families or parents, fathers to look at those resources. And then we end the Dads Group by having a Q&A and then any closing reflections that the dads may have and some chatting or mingling thereafter. Benefits of NICU Dads Group: it reduces feelings of isolation, it creates a sense of community, enhances coping skills and emotional intelligence, or emotional resilience, improves confidence and knowledge of caregiving skills, and then the potential impact on clinical outcomes. So improve parental mental health and reduce stress, strengthening parent-infant bonding, improve parent-parent relationships, enhance collaboration with NICU staff. And long-term benefits include better developmental outcomes for NICU graduates and increased satisfaction with NICU care. This is a picture just showing things to consider when aiming to start a NICU dads group or a parent group of any kind. So first, doing a needs assessment and getting a lay of the land and things that your parents or your population may need, coming up with content and an agenda, identifying a location, time, and hopefully food, and then buy-in from the unit, which is really, really important. I can say at both of our hospitals in the past, and even to this day, nursing administration play a huge part in spreading the word. And there's different volunteers that help out as well. And so having them all understand the importance of supporting our dads, supporting our parents in general in the NICU is very important and helps with this overall spirit of getting parents to these programs. And then last but not least, advertising. So whether that be through flyers or going in person and talking with families, definitely getting the word out there and decreasing the stigma of parents, specifically fathers, needing help. Here are examples of flyers from the past. To the left is our level 3 delivery hospital NICU dads group flyer, and then to the right is our level 4 dads group flyer. This is the one that Mr. Mike is a part of and still runs to this day. And then this was an example of a joint parents group that we had a couple of years ago where we provided a Thanksgiving meal to parents, both moms and dads, and then had like mini breakout groups with moms in one room and dads in the other room. It's a very, very special event and something fun and uplifting for families around the holidays. And then looking at post-group survey data. So this was over the span of 2 years from 2023 to 2025. And of course, it's not everyone that came to the group. We had many, many more people that came, but 40 only responded. They ranged in age from 27 to 48, and you can see their gestational age of their children at birth listed here. And dads ranged in attendance from 1 to 4 times, depending on how long they were in the NICU. And again, we hosted these monthly, so some dads were able to make it multiple times and saw great benefit in the group, while also we saw definitely a growth and just an uplifting spirit for most dads who came back repeat times to update us on how their child was doing, how they were doing, how their partner was doing, etc. And looking at some of the demographics of the groups, you can see here. And then this gets back to publicity and advertising. So the main way that dads identified them hearing about the group was through either nursing or flyers that were around the group or around the unit. And then for us, Mr. Mike and everyone involved, myself, this probably is the most important thing for us and making sure that dads find value in the actual dads group and are getting something out of it. And as you can see here, most dads found the group and meeting to be very valuable. And then this just lists some ideal times. These are all other metrics that you can look at when choosing when and how often to host these groups. And then again, this speaks to the volume of, or this speaks to the magnitude of the group and what dads are getting out of it. And the question was, would you recommend this group to other NICU dads? And 95% of them responded yes, which is great to hear. So before attending NICU dads groups, this shows how knowledgeable dads were about skin-to-skin care with baby, and you can see this ranged in degree of knowledge. And then afterwards, you can see the shift more towards most dads being at least knowledgeable of skin-to-skin care and its importance, which again is part of the educational value that it adds. And then dads responded, over half of them saying that they plan to do more skin-to-skin care, which again is great for families, great for the babies. And here are just some post-group quotes that I want to highlight. When asked why dads attended, the NICU dads group, and if they were talking with another dad, what would they tell them about attending? And you can see here the first one saying, I was hesitant too, but it was the single most helpful thing for me in my journey through the NICU. I felt so alone before, but didn't even realize it. Dad's group helped me recognize how alone I felt and recognize that I really was not alone. And then the second quote, the best way to support your child and partner is to be all in. You can pay for anything and plan for everything, but if you don't show up mentally and emotionally, it won't matter if you're just there physically. Themes that came from our NICU dads groups overlapped, and in large part, many of the dads felt these emotions and central themes. So shared feelings of anxiety, fear, uncertainty, guilt, helplessness, isolation, which are things that Mr. Mike mentioned earlier in the presentation, a desire to be seen and involved. So not just being on the sideline, but being acknowledged, being integrated into the care of their baby, and appreciation for the medical team and care received. This is by far, dads generally are so grateful for the care that they receive, knowing that there are extreme cases out there, and seeing up close and up personal what their child goes through on a day-to-day basis and the efforts that are made to keep their baby alive. So these are last couple of slides, or a few slides, are just looking at different models of NICU dads groups. This one first is in the UK. It's a 90-minute group with intervention based on dialogue between fathers and a male healthcare professional, similar to ours. And overall themes from the study group were emotional support, encouragement, and an enhanced capacity to deal with the situation and with life in the NICU. And then looking at the power of peer support. Again, we've found ways to engage Mr. Mike. Actually, it was his idea to start that dads group at the level 4 hospital. And something that we had talked about and thought about for quite a while, but he really took initiative in helping to start the level 4 NICU dads group. Mr. Mike, do you mind explaining why this was important for you in starting?
Yeah, it's thanks, Cam. I always tell the new dads that come to the group, I going through our time in the NICU, I would come at night and I would feel really disconnected from the medical team, especially at night, because you're not doing rounds and kind of out of touch with what was going on. And it kind of felt like I was just a visitor coming in, so to speak. So, I'm scared for the life of my child. I don't know what's going on. I drive home. I had a certain spot I'd pull over on the way home almost every night and just sit there and cry because I didn't know what to do. And I didn't have anybody to talk to. The dads, any parent going through the NICU, your friends and family care, but unless they've been through it, they don't know what you're going through. So I didn't really have anybody to talk to. I didn't run into any other dads either. So that's the number one goal of this group that we started, is to build a sense of community. And we've seen some great results of some dads maybe don't have the same medical complexity with their child, but they connect with each other. Now they see each other in the hallway. They can stop and get coffee. We've seen some go home and, as we call, graduate and go out to dinner, and they've become friends. We still are friends with another NICU couple we met when my twins were in the NICU 20 years later. So there is a real sense of community that could be built easily. It's just getting people in the same room. And that's probably the number one goal of it. And then just to hear the stories.
Thank you. So looking at some personal research, and I want to be conscious of time. So this is a study that I did during fellowship that looks at parental skin-to-skin care in the NICU, and this particular graph breaks it down by gestational age and looks at mothers and fathers. And you can see that across basically all gestational ages fathers, first time to skin care is significantly more days or time to first skin care than moms, signifying that we can, as a medical team, improve upon engaging and really encouraging dads to hold their babies, and then breaking it down by the number of occurrences. And this was per 100 hospital days. Also by gestational age, you can see that fathers significantly had less occurrences than moms across all gestational ages. This was another abstract that came from the DADS group specifically. And then this was the abstract that showed some of the findings that I just mentioned earlier in the previous histograms. So DADS group making the news. In Chicago last year for Father's Day, we were blessed to have the opportunity to have the Chicago Sun-Times come to the hospital and interview dads. And also WBEZ, which is NPR radio, interviewed us as well and got the word out there about the DADS group. And then, as you can see to the right, the Chicago Tribune, we made the front cover of the newspaper, which was huge as far as just getting word out there and letting people know that there are people in the hospital who are going through really adverse circumstances and really needing support. So how do we take action after hearing all of this? Our call to action as clinicians should be to engage fathers, active partners in care, and then champion the development of dad-focused support initiatives or non-birthing parent-focused support initiatives, and create father-friendly policies. And then everyone can ask, how are you? So I just want to end by sharing this quote with you. This was from a NICU dad who this time last year, actually, or 2 years ago, was in the NICU for an extended amount of time. And we were doing weekend rounds, and we came to this patient's bed, and the dad and both the mom and dad were sitting there. And we asked how the dad was doing, how the mom was doing. And the dad looks over and he just says, paused for a second because he was in disbelief. And he says, nobody ever asked me how I'm doing. They only ask how the baby and my partner are doing. And so they really kind of hit home for not only myself, but Dr. Garfield as well. And again, there's a huge reason why we're doing the work that we're doing here in the NICU. We really do want to know how each father is doing. So how are you? It may come a point in time where you're seeing either a birthing parent or a non-birthing parent sitting there alone or in dismay, disbelief. And you can see the look on their face. And it's in those times where it's even most important to ask this simple but powerful question. And you may be shocked at the response that you get, whether that's in the hallway, whether that's at bedside. Ask the question, how are you? And we just want to share some reflections from post-group surveys of dads who expressed how they were doing. Here are my references. And thank you so much for having us.
Wow, thank you so incredibly much, Mike and Cameron, both for your vulnerability and for your attention to this really important topic. We have a ton of questions that are coming in over the chat. So I'm just going to start with the first one that came through, and we can kind of see where we get and email the rest maybe for responses post-webinar to be shared next week in our follow-up email. The first question we got was, are non-binary folks welcome, or is grounding in shared experiences as male-identified non-birthing parents part of the intended space?
Yes, this is a great question and something that we've wrestled with for sure, finding ways to better include or be more inclusive with all non-birthing parents. And we really, to be honest, we really haven't found a great solution to that. It's something that we've talked about in our family partnership councils and how to address it. But we, do think one of the beauties of this group is having a sense of community and definitely, if it means incorporating more people, that's something that we are considering. But at the same time, wanting people to feel safe and safe space and be safe in the environment they're in order to share and feel heard. So I would definitely take, or we would definitely take any suggestions as far as how to maybe address this issue, in hopes of making the group more inclusive while also maintaining the safeness of that space as well.
Thank you. Do you have any support programs for fathers or families after the NICU?
Specifically, no. We do we have had a lot of dads ask to be veteran dads and come back and share their story with other dads, and several that have volunteered over the years. And so, even hearing from them, that's their way to give back to dads who are in similar situations and circumstances, understanding that no baby or no patient is identical. And so that is one way that dads can serve after they go home. But as far as having dedicated groups to dads who have left the hospital, there's no formal grouping process. Although, as Mr. Mike said earlier, a lot of these dads do form groups and friendships of their own, and we definitely encourage that.
That's great. Does your NICU provide childcare for siblings during these meetings?
Yes, that's a great question. So our level 4 hospital, our child, and that's what I meant by buy-in from the NICU in general. So whether that be child life care specialists that we have at our hospital or the level 4, they definitely do a great job in trying to offload some of whether that be, kids who need to be watched for a little bit of time. If they know a family really needs it and is really wanting to get to the group, there are spaces and opportunities for children to be watched. We've also had dads who have brought their children to the group. Mr. Mike was part of those groups as well, and so that's definitely encouraged. The main thing is them getting to the group, and I think that as long as they get to the group and get to that space, there is something that they can get out of it, and no matter if they have a child there or not.
Thank you. I think the most burning question that everybody wants to know is, and this will probably be our last question as well, would you be willing to share your survey questions or your survey template with us?
Yes, we can do that.
Okay, awesome. Thank you. That's all the time we have for Q&A today. Mike and Cameron, thank you so very much again for sharing today. Christy and Sue, thank you as well. Today was an amazing event and just so much great information and resources. For those who are attending for the first time, I would like to just remind you that I will be sending slides and all of the links shared in the chat, any answers to questions, and a follow-up email early next week. So please stay posted. If you'd like to subscribe to our YouTube channel, you'll be the first to know when I upload the video of today's presentation. And just one more plug for the Gravens Conference, which is coming up in June. It's a great opportunity for family-centered care teaching in a multidisciplinary space, parents included. And I want to thank you all so much for your time today. Thank you for joining us.